So thank you so much for joining us today on this lovely morning in Long Beach. We're very excited to have a multidisciplinary team to discuss this case. And the title of this talk is ICU to Home, Manage Parenteral Nutrition in Complex Adult Patients, the short bowel, but it's a long journey. So anybody who manages intestinal failure can certainly attribute to that. So here are my disclosures, and then also Christan Bury's disclosures, and then Sarah Cogle's as well. So our objectives today, we really want you to take away and identify key clinical indicators for initiating PN in critical ill surgical patients, really apply advanced nutrition assessment techniques to really guide our PN formulation and dosing among adults. Evaluate strategies to prevent PN-related complications among adults, both in inpatient and home settings. Understand the interdisciplinary roles of physicians, dietitians, and pharmacists. And we apologize, we haven't added nurses as well, but certainly they're a valuable asset to the team in PN management. So we really wanted to strive and do a multidisciplinary talk today, looking at various strategies to optimize individualized nutrition support and help improve outcomes. So let's get started. So I will start off with presenting a patient case. So this is a 72-year-old gentleman, past medical history of type 2 diabetes, hypertension, dyslipidemia, and he's had previous multiple open hernia repairs with mesh in the past. He also has obesity, and notably he started a GLP-1 6 months ago, and he presents to an outside emergency department. Chief symptoms at that time was abdominal pain, and then he was noted to have significant hyperglycemia in the emergency department. And then on a CT scan, there was concerning that there was an intracutaneous fistula that was about to develop, but there was a lot of intra-abdominal sepsis and collections, question of necrotizing fasciitis of the abdominal wall. So a pretty sick guy initially. You can imagine also when you get these transfer patients, some of the notes in clinical history is a little bit sparse, so this is what you get when you first start off. And then in the outside hospital, he had a status post-ex-lap, a lysis of adhesions, oversewing of an open fistula, small bowel resection, colon in discontinuity with a wound vac placement. And then he was transferred to your tertiary medical ICU for higher level of care. He was pretty unstable on transfer as well, and then again he returned to the OR for a repeat XLAT, lysis of adhesion, and small bowel resection. This is where we really rely on our surgeons for the anatomy of the bowel when they come out of the OR. So this surgeon luckily recorded the amount of small bowel. It's 160 centimeters remaining to end ileostomy. So for those of you who don't know, I really want to just provide an overview of what intestinal failure is. So the definition is the reduction of gut function below the minimum necessary for absorption of macronutrients and or water and electrolytes. So it's usually required to have some sort of IV supplementation in most patients or very aggressive oral therapy to keep up with their needs. There are phases of intestinal failure. So certainly there's type 1, which is the acute, short-term, usually self-limiting condition. There's a type 2, which is more the prolonged acute condition, metabolically unstable, and this can last weeks to months. And then finally, there's the type 3, which is a chronic condition. Usually this could be months to years. Generally, it could be reversible or irreversible, and they're metabolically stable. And I highlight a photo here that I really like to structurally think of it in my mind, that after surgery, certainly in this patient, this is a new short gut, 160 centimeters, you're thinking, priority is fluid and electrolytes and parenteral nutrition, that IV support, and then what can we, in that acute phase, and what can we wean off to use the gut or enteral nutrition, usually later on. The etiology of intestinal failure, it's a very big slide, and I apologize for that, but I really wanted you to get away with some different types of conditions that can lead to intestinal failure. By far the most common is the short bowel syndrome. So this is a serial or massive small bowel resection like this patient. Usually it's from Crohn's disease or malignancy, or in this case, mesenteric vascular insufficiency. So with that open hernia repair and volvulus, that led to the resection in this case. Of note, there's also extensive mucosal diseases, including Crohn's disease or autoimmune enteropathies, mechanical obstructions, so the gut can't relieve in bowel lesions or adhesions, dysmotility like chronic intestinal pseudoobstruction, as well as fistulas. Of note too, there's also, when you think about it, so we talked about the three types of intestinal failure: acute, subacute, and chronic. There's also the most common, which is short bowel syndrome, and there's also three types within that too. So type 1, and this is by anatomical, again, relying on your surgical colleagues to look at the anatomy of the patient. So type 1 is angiogynostomy or ileostomy, the small bowel right to, with no colon or ileocecal valve. These are generally patients that are very high risk for dehydration and electrolyte imbalances and generally need IV support. Type 2 is jejunal colonic anastomosis. The key here is that you have small bowel attached to the colon, but in general you have the ileocecal valve removed, so you don't have the entire colon intact. And type 3 is the jejunal ileal anastomosis. When I was in training, one of my mentors said to me, the best part of the small bowel to lose is the jejunum, if you will. We love the jejunum. But these patients, the type 3, generally do well because they have the ileocecal valve, so they have that hormonal ileal break, and then they have the entire colon. So this patient, we're a little bit worried about him. You know, he's not a well patient. He kind of has metabolic syndrome, obesity, type 2 diabetes, dyslipidemia, massive small bowel resections, and he's type 1 short gut. So certainly everyone in this room is worried about their nutrition, so I'll hand off to my colleague to go over the nutritional assessment that we would do in ICU rounds.
Thank you, Dr. Russell. Yes, so the dietitian is present on rounds. You look through your patients and we notice we have a new admit. And I think dietitians do a great job of highlighting that ICU day 1 for your hospital may not be ICU day 1 in that patient's journey. So our patient, he's 5'7", he's obese with a weight of 240 pounds and a BMI greater than 35. But we noticed that there was a significant weight change pre-op, and we learned that he was recently started on a GLP-1. And I just want to highlight a lot of these case studies we make up. This one is so close to home because we're seeing a lot of these medications prescribed in the outpatient setting, but then there's not a lot of follow-up for these patients. So we see a 40-pound weight loss, which was intentional, but we're questioning, was that of medical benefit? So I do a physical exam, and I'm not able to appreciate much loss, maybe a little mild in the quadriceps, the clavicles, and the temporalis. But upon further investigation, we talked to the wife and learned his ADLs have declined at home. He doesn't have, the functionality that he used to. We also have a CT scan, which I'm trained to read for malnutrition. We're not using it to diagnose currently until the guidelines can support it. But I will highlight that I'm appreciating when there's low muscle stores. I'm taking that CT to rounds and saying we need to consider nutrition support as soon as possible. So with poor intakes and low muscle stores mildly upon a physical exam, we diagnose moderate malnutrition. I also took an ultrasound of his quadricep upon admit. One image tells us very little, but for patients that we know are going to have a prolonged stay, we can track changes. So again, I want to clarify that I'm not using body composition to diagnose malnutrition within the AIM or GLIM criteria because there aren't established cut points. But as soon as there are, we're excited to start. Just briefly going over ultrasound and CT. Ultrasound uses high-frequency sound waves, and we can delineate different tissues. It's very quick, it's easy, it's portable. I bring it to the bedside. It's a small tablet, and I use a linear probe. It is prone to technical errors, but we are doing a competency at the Cleveland Clinic to make sure our percent coefficient variation is appropriate, and we're just in the beginning stages of trying to train others. And now computed tomography, it's obviously more accurate than ultrasound. It's not available in all patients, but of course in a surgical ICU, you have them. And also in patients in the outpatient setting where you're getting routine CTs for various reasons, you can see the changes of muscle and fat throughout time. Ultrasound can evaluate the muscle size and quality. Here we have the quadriceps of a healthy person. You can see very clear delineations between the different muscles of the quadriceps. And with certain technologies in real time, we can evaluate size, the quality, the echo intensity, and the changes. And we can also evaluate changes in fat. This is more of an example of the ultrasound quadriceps that I see in my patients. Here is a patient from a study we did. As you can see, the muscle is much smaller at baseline than the previous one. You can barely tell the quadricep muscles interfacing, and you can see the significant change. And this was a patient that we were feeding well. Moving to CT, skeletal muscle index can be an important measure to track, and it can indicate sarcopenia if you combine it with functional tests. When we have a CT and we get the cross-sectional area at L3, we can calculate the skeletal muscle index by dividing the skeletal muscle area, which is the number 97 there circled in red, and you divide it by the patient's height in meters squared. And there are many papers that explain sex-specific cut points where the range below that would be a patient with low muscle. So again, I can't wait for hopeful, we'll have tertiles of cut points and we can say that person is mild, moderate, or severe and combine it with our physical exams. Here's one more example just of how much I feel that we're missing in certain patients with larger bodies. We have a patient with obesity. My physical exam shows very little muscle loss because you can see the subcutaneous fat in blue is masking any of his low stores. So I'll get off my soapbox about critically obese patients, but they're just a population where I think we can intervene assertively with specific intervention and hopefully improve outcomes. Briefly, I'm going to talk about protein in the critically ill. We see the updated ASPEN guidelines, and the question is, in adult critically ill patients, does the provision of higher protein compared to low improve outcomes? And there was no clinical difference in outcomes and very limited data. But I'd like to highlight a few of the larger studies that anyone in critical care has heard about. First, the EFFORT trial. This was an international, singly blinded, randomized trial. They included over 1,300 nutritionally high-risk adults and prescribed them either high protein, which they defined as greater than 2.2 grams of protein per kilo, or low protein, or the usual protein, which is 1.2 grams of protein per kilo. Their primary outcome was time to discharge alive, and their secondary outcome was 60-day mortality. The results showed that the incidence to DC alive was higher in the usual protein group, and the 60-day mortality was lower in the usual protein group. They also did a subgroup analysis concluding that high protein was harmful in those with AKI and organ failure at baseline. So if you're just reading the abstract, the framing is that higher protein is harmful, but I want to discuss further details of the study to talk about the conclusions. First, if you look at the exclusion criteria and the methods, they specifically excluded those patients where the clinician used clinical judgment to say that lower high protein would benefit. And we all know how much we're using our clinical judgment at Bayside alongside the guidelines. Also, they did not specify how they assessed proteins in the extremes of BMI. For example, using a 2.2 gram of protein per kilo for a patient with a BMI of 35 would not be appropriate. Third, they did not reach their protein goals. The high protein group received about 1.6 grams of protein per kilo, and the low protein group received less than 1 gram of protein per kilo. Next, nearly half of those enrolled were medical patients versus surgical ICU patients. Over 50% denied having any issues with intake prior to admission. 80% did not have any GI or malabsorptive issues, and 65% did not have moderate or severe wasting. Additionally, both groups had BMIs of 28 to 29, which anyone working in the ICU knows that's an excellent BMI with the lowest mortality compared to BMIs less than 20 or greater than 35. Now, high protein in AKI could be harmful, but they did not discuss whether AKI meant they were receiving continuous renal replacement therapy, in which case higher amounts of protein are universally recommended. And they also said in the conclusion there are specific groups where higher protein is necessary, including burns, trauma, surgery, and patients with obesity. So what this study is showing me is that nutritionally low-risk patients who are mainly medical, they may benefit from a protein range of 1.2 grams of protein per kilo, which is exactly where the ASPEN guidelines suggest. Also in 2023, there was a post hoc analysis of that subgroup we talked about in the previous slide, those with AKI. Again, I want to reiterate that 90% of the patients were medical and not surgical. We see those with AKI, a higher protein was associated with a slower time to discharge and alive, and a higher 60-day mortality. It's important to note that the authors report that protein dose was not significantly associated with AKI and kidney replacement therapy or the duration of kidney replacement therapy. So my takeaways for this are that once there is an AKI, we should consider modest protein if these patients are not going to be dialyzed. But once kidney replacement therapy is initiated, we need to increase protein to meet the demand. Now we come to 2024, a systematic review and a meta-analysis of randomized controlled trials and the effects of higher versus lower protein in the critically ill. It evaluated 23 RCTs, including over 3,000 patients with protein delivery. Overall, higher protein was not associated with mortality. In fact, higher protein plus early physical rehab trended toward an improvement in quality of life and functional measures at 90-day mortality. One more study, the PRECISE trial. This aim was to establish whether high enteral protein provision would improve health-related quality of life functional outcomes in critically ill patients. They were randomized into two groups, one with 2 grams of protein per kilo and one standard, 1.3 grams of protein per kilo. And the primary outcome was quality of life at 30, 90, and 180 days post-randomization. The second outcome was mortality. The results showed that higher protein had lower quality of life and a higher incidence of GI mortality and symptoms. If we look at the patient demographics, we see the BMIs in both groups were extremely favorable for an ICU environment, 27 through 28, which again we know is associated with lower mortality. Additionally, there's most of the patients again are medical and not surgical, and they had minimal GI issues. So my takeaways for this are that in a medical ICU patient with a desired BMI, a protein range of 1.3 grams for enteral support seems appropriate, which again falls in line with the recommendations. But if you read this study again, they mention malnutrition one time in table 1. And so I'm not here to disparage these studies. They're wonderfully done. I think randomized trials in nutrition are hard because we know in our heart that probably feeding some type of protein is good, so we're never going to enroll those patients with high risk. I think critical illness is a spectrum, and you have patients that are well-nourished, and if we feed, it probably doesn't matter how we feed you, if you have good functional status prior and it's not a long illness. And then we have patients on the other end who are so frail, very ill, malnourished, chronically ill, and their outcome is probably going to be poor if you have more than a few days in an ICU. But it's the patients in the middle where they have maybe reduced function, they're obese, but they still have some muscle loss, but they're not too far gone. And these are the patients that are excluded from all of these studies. And I understand that. But these are also the patients, like the case study today, where I think it's important to advocate. So here, back to our patient. He's ICU day 1. He's intubated on pressors, propofol and insulin drip, and we want to be able to feed him. And of course, the gut isn't functional because he's in discontinuity. And we anticipate with 2 ORs already and with his ostomy, we know that we won't be able to feed right away. We also evaluate his serial CT scan showing muscle loss in the pre-op setting. So the question, when should we start nutrition support and consider parenteral? Of course, we want to try to use the gut, and I will say that is always what I try to do, and I often have surgeons who will say, not yet, I'm not comfortable, and I have to honor that, and I want to start enteral as soon as possible. But with this patient, knowing that I can't feed, he's already 40 pounds down, even if he thought it was intentional, it was not a medical benefit with that rate, and he's had poor intakes with his second hospital stay. So we are going to start parenteral support, and I'll just highlight anecdotally in my practice, I'm starting parenteral support and using it supplementally a lot more than I did like 10 years ago, just because of how sick patients are, because we know the delays in feeding. Okay, so now we need to evaluate if we're going to give him parenteral support, how are we going to feed him? We know he is obese, so here is the ASPEN guidelines how we should use, based on your BMI range, different, whether it's actual weight or ideal body weight. But we also we have an indirect calorimetry for this patient, which I was able to do. So indirect calorimetry allows clinicians to measure variability between patients across time. It's the gold standards to assess energy needs, and it's associated with decreased ICU and hospital length of stay and reduced rates of infection and mortality. So here's this patient's metabolic cart. We used his 109 gram Weight for dosing, we know he has moderate malnutrition. I often, if I have a cart, I'll still do the calories per kilo. So if we go within the guidelines, 11 to 14 calories per kilo just seemed so low to me for this patient, especially with his malnutrition. So his MREE was very high. I was honestly surprised at this rate, but I fed to it, and this patient did very well and came off the vent a week later. But I didn't get to this amount overnight. I also added 13% for CRRT, which we'll talk on the next slide. For his protein, I did 2 to 2.5 grams of protein per kilo of his ideal body weight. So he's critically ill, and I fed that rate. I want to say I didn't get to that rate overnight. I fed full protein. He was on propofol initially, which often augments the calories out of my control anyway. And we checked everyday blood sugars, made sure that the insulin drip was appropriate, and we did meet this goal for several days. Let's see. We advanced to macronutrients over the course of the week, depending on his volume status. We adjust his electrolytes, and once propofol is weaned and we know that it's not going to be resumed, we start lipids. So we have our patient, he came to us in discontinuity. He went to the OR and has 160 centimeters of small bowel, and we start parenteral support.